Well, thank you all for joining us. This is the last, but certainly not the least, virtual tumor board session of the year. So thanks everybody for calling in. As you know, the format, 3 cases around 20 minutes each. And we're very excited for today's session on reconstruction. Dr. Chad Zender of University of Cincinnati and Dr. Rusha Patel of Oklahoma University are the liaisons to the reconstructive section. And thank you guys very much for organizing such a tremendous faculty and discussant complement. So I'll let you take it away. And also any comments or questions, put them in the chat box and I'll filter them back to the group.
Awesome. Thank you so much. I actually think our first discussant is Alice, if she's on. We can go ahead and start with that case.
All right, perfect. Let me share my screen.
Yep.
Is that working?
Yep.
Perfect.
Perfect. All right. So, hey everyone, I'm Alice. I'm from University of Cincinnati, and the first case is going to talk about lateral facial parotid defects with one of my own patients. So this is a 68-year-old male. He shows up to my clinic like this. His past medical history is significant for he has a mechanical valve, so he's on Coumadin. He used to smoke, but he no longer is smoking at the visit. This mass has been present for 2 months. He went to an outside ENT. They thought it was an abscess. They treated it with antibiotics. And then finally got biopsied and it showed keratinizing squamous cell carcinoma. And I see him in my office. There's about a 3 to 4 exophytic mass. It's mobile. It's not fixed to the mandible. And the facial nerve branches appear to be all intact. The workup includes a CT scan, which on this axial view, you can see that it's kind of not very well demarcated on that scan, but here's a better look at it where you can see normal parotid tissue deep to it. It doesn't seem to be too infiltrative deeply. And on the coronal, you can kind of see the exophytic nature of it. There are no enlarged lymph nodes that appear to be pathologic. However, he came with a PET scan, which is a frequent occurrence with people coming in with these processes. And there is a little tiny avid node in level 2 on the ipsilateral side without any obvious CT findings that would be too concerning. So my
Alice?
first yeah, can you hear me?
Oh, sorry. Even before you get to this question, I
Sure.
thought maybe we'd ask David, Dr. Cognetti, what his discussion would be with someone like this regarding the facial nerve, even before they get to the OR, and what his thoughts are in someone like this based on that scan, and whether or not he'd get any other imaging. Oop. David, you might be muted.
Got it. Yep. So thanks, Chad. Yeah, I think that's an important thing to bring up here. I would certainly have a discussion about the facial nerve. If you go to this scan, I think it's telling in terms of how to direct the discussion, because you're going to the operating room for a cancer involving the parotid. You want to discuss the facial nerve, but you don't want to overdo the discussion if you don't need to, if you will. You want the patient prepared for what's realistically possible, and you want to be prepared yourself for what you may need to reconstruct. Looking at these cuts here, you can tell that the tumor is pretty inferior with regards to the parotid involvement. You're looking at the sternocleidomastoid muscle. You're well below the mastoid tip. It is invasive into the parotid parenchyma, and combining those two things, I think at most you're risking lower division branches. So cervical, maybe marginal. And, you know, that makes it easier in terms of what you're preparing the patient for, in terms of expected outcome, and what you're preparing yourself for if you're planning a neurorrhaphy or something like that. But I would talk about the possibility of facial nerve injury in any parotid surgery. And then in somebody with cancer, I would try to give them a more personalized assessment of their risk of what parts of the nerve and the likelihood of it being permanent.
No, that's great. Any value in MRI in this setting, do you think, or not really?
I think this is a nicely contrasted CT scan. You got a complementing PET scan. I don't think I would put this guy through an MRI. Alice, I'm sorry for not catching every detail of that thorough history, but I know he's got a valve and this and that. I know if I say MRI, you'll tell me he has a pacemaker too, and I wasn't paying attention. So yeah, I don't think I would need an MRI for this particular situation. If the guy had come with no imaging, I think an MRI is nice.
Great, thanks.
So my first question is, what margins would you take on a cutaneous squamous cell carcinoma of the head and neck that is rapidly growing, and he does not have any other risk factors, i.e. he's not immunosuppressed, he's never had a transplant or anything like that?
Okay, the poll's open. We'll close in about 5 seconds. Closing.
That's good. That's about the margins I took, about 1 centimeter around what I can see grossly from the disease. And we'll talk about a little bit about what surgery ended up happening. But it actually leads to the second poll question, which is, how much surgery do you do for this? Would you just do a wide local resection, wide local resection with a superficial parotidectomy, wide local excision with the parotid, and then you do a sentinel lymph node because maybe it's high risk? Or would you do a wide local resection with the parotid and a selective neck dissection based on the imaging and that node in the PET scan?
Okay, closing the poll in 5 seconds. Closing now.
Wow, 100% consensus. That's pretty good.
Yeah, well, I was going to ask her, gee, what he was going to do or what his plan would be, but I think we know. But
yeah, I feel the crowd has spoken. Wow.
Still, G, can you elaborate a little bit? Would you ever consider a sentinel node in someone like this, or it just doesn't make sense?
Yeah, so a couple of things. One is, first of all, as David mentioned, this tumor is invasive to the parotid, so I don't think you can really exclude the parotid. That part's easy. There's no way to safeguard the facial nerve if you don't do sort of a formal parotidectomy. For neck dissection, what makes this one easy is that I think the size of the defect is so substantial that some amount of reconstruction is going to be done. And at that point, there's kind of no reason why you would toy around with anything less than elective neck dissection. It would be probably more of a challenging question if either the lesion was more subtle, and then you're debating elective versus observation, and sentinel node might be the sweet spot for such a case. So for me, it's the size of this lesion that makes it a no-brainer. A more subtle case would then raise the question for C being a potentially good answer.
Dr. Kakarala, do you have any comments, anything different from your perspective?
No, I fully agree with her. If you're going to make big incisions for this, the level 2 and 3 will be right there. It's easy to do, better to do up front as opposed to trying to chase it later.
So he underwent the wide local excision with parotidectomy, elective neck dissection, take it to the frozen room. I inked it, cut it in half, make sure we were clear, and frozen pathology showed that we were indeed clear. So I didn't have a picture of that particular defect. However, I have a picture of another defect that is similar, except it's a bit higher. So here's the facial nerve. Elective neck dissection clears out level 2 and 3. You have a defect higher up. On my patient, there was more of a volume defect, more inferior. And so just to give you an idea of what that open wound might look like and what you're considering for reconstruction at this time. So the poll question would be, how would you reconstruct this? This is a local pedicle regional or a flap top, but I did put in free flap in there in case I was totally out of line. A submental island flap, a supraclavicular flap, or some type of cervical facial advancement flap, not really knowing yet if this person will or will not undergo radiation.
Closing the poll in 5 seconds. Closing.
We got one lateral arm. I like it.
I couldn't pick something else since I did a submental flap on this patient. I figured I had to pick that. But Mike, Dr. Moore, what are your thoughts? Would this patient get a free flap at your institution, or would you guys do a regional flap?
Yeah, I mean, I think certainly for the actual defect from the case, I think supraclavicular would be perfect. I think for this one, it still would likely be good, but it's one that you would kind of test the limits of the upper part, but typically you end up having plenty of length, especially if it's a nice wide kind of hardy flap. It looks like body habitus wise, it'd be reasonable. I found things like thigh flaps are very, very bulky a lot of times for this, and lateral arm is great, but for a higher defect, I guess you potentially could have a little issue with pedicle length, but probably not, because you'd have an EJ right there. So in reality, I'd probably use a supraclav.
I know that Technos and Old and the Ohio State folks really like the lateral arm for these lateral defects. They think it's a good color match, which certainly makes sense, like you were saying, and probably better than a big bulky ALT. Dr. McMullen, anything you would do different?
No, that's pretty much what I would do. I do like submental for this defect. I think the color match ends up being really great, and the bulk is kind of right in the middle, not too much, not too little.
So that's what we ended up picking for this patient, both of the patients and both defects. So a submental island flap was used to reconstruct that area. And, he ended up with this defect here, and it swung up pretty well and inset it and contoured nicely in that area. And so some of the considerations that, we think about when we're constructing this type of defect is, of course, coverage in case the patient will undergo radiotherapy. You have good vascularized tissue in that area. And so in such a sensitive place, you definitely want to think about the color match, the volume, some aesthetic contouring of that region, and the ease of harvest. If he is unhealthy, if there are multiple comorbidities, you want to get him off the table. Submental or supraclavicular flaps are generally quick and easy to do. And this is just a question because I think that I could learn from this. How do you orient your submental island? Do you do it vertically or do you do it horizontally?
Closing the poll in 5 seconds. Closing now.
So about 50-50.
That's amazing.
We needed one that said both, because if it's just for bulk, sometimes I'll do it vertically to hide it better. If you need a length where you're getting above the zygoma, sometimes that horizontal. But I'm curious, on that same token, to Urjit and Russia, what do you kind of define as the limits in terms of either height or size when you're trying to decide on submental, supraclav, or do you need a free flap?
Sure, Rusha, do you want to take that first, or should I go?
Well, I guess I can tell you in my experience that you certainly have more of it. I just kind of go by what the patient's going to give me. So, if they're older and have a little bit more skin laxity, and I'm going to get a bigger defect covered with that kind of patient. And in terms of superior extent, I haven't gone above the helix, though I have seen people kind of extend the flap a little bit higher. But I'm curious to hear what your guys' experience has been over there.
So, yeah, I agree. It's patient specific. So usually a little pinch test of the neck will give you what the width of your flap or what the short axis could be. I almost always will position a submental horizontally or maybe obliquely if it's a unilateral neck dissection. And then for the distal tip, you can go all the way to the contralateral angle. And so, but I would say the top of the helix is probably as far as I've gone in a pedicled fashion. But as long as you take the ipsilateral half, you can go to the contralateral angle of the mandible, and you'll get random circulation there. So So it depends on the defect, how much you have to reach. But the horizontal positioning allows you to get very, distal or contralateral harvest, which then allows you to get a much greater arc of rotation.
Do you still take the mylohyoid with yours, Urjit, or have you modified that since then?
No, never turned back. And it's what has consistently allowed me to leave this in the hands of a, first month fellow or a chief resident, and they get to do the dissection because I don't have to worry about, a pedicle dissection, which, I think if you leave the mylohyoid behind and really dissect the submental pedicle, the complexity is somewhere between a perforator flap and a forearm flap. It's not quite as easy a forearm, not quite as difficult as a perforator, but both of them it becomes a real chip shot if you take the myelo with you and puts it into pec flap territory in terms of complexity. So I still do it that way.
Got it.
And then my last polling question is, if that defect, this is a different defect, involved a zygoma and was a recurrent case, was radiated previously, would this change how you manage this? Would you continue to do the submental, or would you do something different?
So in this example, is the question more, Alice, around the defect involving the zygoma or using this flap in a previously radiated patient?
Right. She threw two things at us.
Yeah, using this flap in a previous radiated patient, would that bone, eating away the bone, do you just kind of leave it? Would you want to reconstruct that? Or would you just say you're just going to have a little bit of a defect there? 50-50. And the only reason I brought this up, because I actually thought it was a really interesting, as I was reading this, that there was you could do an osteocutaneous submental flap by taking part of the mandible. And that's what these authors did. And just as they're more experienced, if anyone has ever done that, because it sounded really neat and crazy to me.
Yeah, I'm curious about that, and I don't know, David, the troops at your institution, yourself, or and I personally wouldn't do a submental in somebody who's got neck radiation. That's just me. A lot of times they don't have that laxity, and I worry about the tissue quality. But curious what other folks, David.
Yeah, no, I'm the same with you, Chad. And looking at this picture, he's got no laxity, it looks like, to begin with. And then he's got the skin fibrosis and everything else. I have not seen an osteocutaneous submental flap, to answer your question, Alice. So please do send pictures if you do one.
Karan?
You calling on me?
Yeah.
Yeah, so I think this would be great for osteocutaneous forearm. We do a lot of those, and these kind of smaller mid-face defects, you could just take a small piece of bone, and I've done almost this exact same defect, and it looks really great. In a radiated patient, I think that would be preferred.
Over the osteocutaneous submental for the first time?
In my hands.
I mean,
Mine too.
Okay. It was like a mission trip. I think they were in Africa, so it was kind of their other hand side. All right, so the pathology report, we have 1 minute left. No perineural invasion, no lymphovascular invasion. All the nodes were negative. So there's a PT3 and 0 presented at our multidisciplinary tumor board. Talked to radiation oncology, but we decided to watch him, and he did great. So this is the original patient, 1 month post-op. There's some pin cushioning with the submental. The reason I didn't love my horizontally oriented is that I had this stupid dog ear there that stared at me for like a month for months. But this is 6 months out, and that pin cushioning kind of went away, and the dog ear was, of course, still there staring at me. And this is my last slide, just to show that it's kind of nice to have that submental volume fill that parotid parenchyma defect, and it actually ended up contouring quite nicely. And that's all I have.
Awesome. Thank you, Allison. That's right on time. And Russia, I'll let you moderate, and then we can tag team the last one, something like that.
Sure, that's fine. Alice, that was a great case. That was really nice. So we got Caitlin next. Dr. McMillan's going to talk about a case of a laryngectomy that went the way that most of us are unfortunately a little bit too familiar with. So if you want to go ahead and share your screen, we can get started.
Sure, I'd be happy to share my case of shame.
Well, the beauty is we've all been there.
Yes, we all have lots of those. No shortage.
Yeah.
All right. So I'm Caitlin McMullen. I am a head and neck surgeon at Moffitt Cancer Center in Tampa, Florida, and glad to be here. So today I'm going to talk about a primary laryngectomy case that went south, and I'm curious to see what all of our participants would have done differently than I did. So this is a 76-year-old gentleman who presented to my office from an assisted living with a trach and a G-tube done about a month prior to an outside hospital for shortness of breath and hemoptysis. He was on trach collar oxygen when he came in. He was eating despite the G-tube. I'm not sure what instructions he was given, but he was doing fine eating by mouth. He has a history of COPD and hypertension, BPH. He was a former heavy smoker, but hadn't smoked in a number of years. He was kind of on his own, BMI 24, not terrible. And you can see this irregular mass lesion involving the right vocal cord extending a bit to the supraglottis. His right cord was immobile. Full staging was complete, and it looked like a T3N0M0. He was not interested in chemoradiation. He wanted to proceed with surgery. The logistics, especially for chemoradiation, were not feasible for him. Plus, he had a non-functional larynx, so laryngectomy was preferred anyway. I was a little suspicious about the use of oxygen because he would come into our office and it wouldn't even be turned on and it'd be looking fine. So we actually weaned that off, and turned out he didn't really even need it. It was just kind of poor follow-up on his part. So actually, I could probably put this in slideshow view. Well, I'm failing right now, but intraoperatively, the piriforms were clear. Let me see here. Let me get a better view. There we go. Piriforms were clear. The post-cricoid space was clear. The base of tongue wasn't involved. It was all endolaryngeal. We preserved the thyroid. Margins were negative on frozen section. Did bilateral neck dissections. We closed the pharyngotomy with vertical line closure with a canal suture and a second imbricating layer over that and placed JP drains. His final pathology was a 4.8 centimeter poorly differentiated squamous cell carcinoma without perineural invasion, lymphovascular invasion. Cartilage invasion was not identified. Closest margin was 8 millimeters, and he had no positive lymph nodes.
So
go
ahead.
What?
Oh, I was going to say, going back to that last slide, I thought a good thing to kind of cover, and we can start with your thoughts on this. How do you determine that you have adequate pharyngeal mucosa to close primarily? And we can ask some of our panelists as well. Yeah, so, there's a bit of an eyeball test, making sure that there's a good stretch. I like to measure it also, have at least, 4 or 5 centimeters plus, 6 is nice, across the diameter. So, his was entirely endolaryngeal. There was basically no pharynx resected. So he had plenty of mucosa. Do the other panelists do formal measurements or other kinds of formal assessment? I guess, we can start with probably Dr. Cognetti if he's on, and see what he does, and then kind of go down the line. Because I'm curious about this. It's kind of variable.
Yeah, so sure. Caitlin, I agree with you. My anticipation going into this case with this tumor being completely endolaryngeal in somebody who is non-radiated, I would anticipate that you would be able to preserve the piriform sinus mucosa and have no problem closing. So it's not really based on a measurement. My mentor, who did not train during free flaps, used to say that if you can close a pharynx over an NG tube, you can close a pharynx, which he also had a very busy esophageal dilation practice on post-laryngectomy patients. So I wouldn't judge it on that. I think nowadays we go in knowing based on where the tumor is it out of the larynx, is it a radiation failure? And we're already prepared for flaps based on those things, not based on the size that's left necessarily.
Yeah, completely agree.
Urjit, were you going to add something to that as well?
Sure, I can chime in. I'm probably dating myself, but I at least heard the stories of closing it around an NG tube, but at least we changed it to if you can close it around a chest tube, you're good. So we, by my generation, we might have changed a little bit. But I agree with what David said, is that in an endolaryngeal, and what Caitlin said too, in an endolaryngeal lesion, I don't even think twice about it, you will have enough to close primarily. And it's only for, supportive coverage, like in a radiation case, that you might think you would need a flap for a patient with this anatomical amount of disease. Once it starts involving a piriform or the postcricoid, that's a different story. And then, I will actually take 2 DeBakey's, go to the narrowest portion of the remaining mucosa, make a measurement as Caitlin was describing. And again, you think about diameters versus circumference, I want at least, 5+ centimeters of width to give me a circumference of at least 1.5 diameter of at least 1.5 centimeters. And that's probably analogous to a chest tube. So that's probably how I tackle that question.
Awesome.
Excellent.
So we can move on to the next slide. Thank you.
All right, here's where the shame starts. So he got his usual perioperative management, 24 hours of antibiotics, PPI, chilling out. Post-op day 4, started having temperatures up to 101.9. His neck was looking red. It was kind of swollen, edematous. His white count did remain normal. He had tenderness out of proportion and than what you would expect for that point. It was pretty clearly fluctuant at some areas. So I took out the drains and opened up the neck on both sides and packed with betadine with copious salivary drainage from both sides. I like betadine soaked gauze for when it's starting out red, when he's having fevers and it looks actively infected. I'm sure that's not, evidence-based, but when it's actively looking infected on top of just a pharyngocutaneous fistula, fevers, erythema, I like to start out with betadine soak packing. That was requiring changing 3 times a day. I did restart antibiotics at that point too. Check some labs. His albumin was a bit low. We knew that from before surgery, though. It's about where he was. His TSH was in the normal range.
So I would not call this the slide of shame. I would call this a slide of experience. Because like I said, I think this has happened to everybody if it hasn't been operating enough, right? So a couple of good things on this. I'm curious, especially, there's so much variability in the initial fistula management. Like Caitlin said, betadine soaked gauze, you pack it with Dakins, do you pack it at all? Do you leave it be? Karen, if you're on, I'd like to hear how you do it or how some of the other panelists do it as well. Just kind of an experience type of thing.
Yeah, I think this is exactly what I would do. We use acetic acid, but I don't think it really matters. Some people use Dakins. You can dilute it. It's basically bleach. Dan Deschler used to joke that you can choose whether you want your patient to smell like a swimming pool or like a salad. So we pick a salad here, but some people like the swimming pool.
Oh,
Probably
that's
smells
awesome.
better than what else is going on in there. So
Yeah. And I think in this situation, the antibiotics, make sense. The guy had a fever and all this. But, I don't know that antibiotics are ubiquitously used. So are there people that would ubiquitously implement antibiotics for fistulas or just kind of like a case by case basis? I guess we can bounce back to Urjit and kind of see what your practice is.
Sure, it sort of depends. It depends on how bad the neck looks. Does it seem like fistula? Does it seem like an infection? And understanding that there's a continuum there. What I would say is that if I was actually packing the neck with betadine, I would not think that is infection free. So I would not call that just fistula. So if I think it's bad enough or ugly enough that I'm packing the neck, I'm certainly starting antibiotics. On the flip side, if the neck didn't look that bad, not so much purulence, more like saliva, I might really consider, rather than packing these necks and opening broadly, I would really think about Penrose drains, pressure dressings, and then probably the last thing, which is kind of an unusual maneuver, which I got from Randy Paniello at WashU back in my time. is actually for the ultimate controlled fistula. What we would do is we'd actually put a mushroom catheter. That's like a urology kind of thing. We'd actually try to get that all the way into the pharynx, through the fistula's hole into the pharynx, and put that on continuous suction. And so the idea is that you've now completely controlled the fistula, and the rest of the neck has sort of an optimal opportunity to heal. And then eventually you'll pull this mushroom catheter. So there are a couple, maneuvers of fistula management that may differ from various members of our panel from one to the other. Not sure which, probably none of them are evidence-based, but again, I would say if the neck looks really bad, I'm going to think about packing and either Dakins or betadine, and certainly, intravenous antibiotics. If on the other hand, it doesn't look like, so much infection as much as fistula, I'm going to think more about Penroses, pressure dressings, maybe mushroom catheter on suction.
Well, I've never heard that one, but I will have to try that one next time. That definitely sounds
one last question on the mushroom catheter. I really sort of swear by it. And I'm looking at my fellow, and I don't think we've had an opportunity this year to use one, which is a good thing. But here it's usually not on round one that you put in the catheter. You kind of train the necks, put in your Penroses, and only when after like 4 or 5 days you're not really seeing some improvement, then at the bedside with a hemostat and a mushroom catheter, I'll try to direct that completely endopharyngeal through the neck, put that on continuous suction, and then either, pressure dressings or packing, and the rest of the neck is really saliva free and gets a chance to heal.
Sure. Caitlin, you'd mentioned some of the medical issues that this patient came in with, and his albumin is low, like you said. What are you doing at your institution, or what are your preferences about medical optimization in this case, knowing he's, not in the best state of health, he's going into a laryngectomy case, you want to try to prevent fistula as much as possible and kind of preoperatively optimize them?
So I do quite a few things, depending on, a lot of it depends on the patient's ability to follow up with those things and work with our other services, but I'll check a TSH in patients who've been radiated. I don't typically check it in patients who have not been radiated before. I have them meet with nutrition to make sure that they're getting adequate protein intake and supplement them if needed. There are some patients where I've been really worried and requested impact feeds preoperatively, although that's been hard for us to get approved. So typically, really just TSH. I don't necessarily check a full panel of nutrition labs, especially somebody like him who's got a BMI of 24. He's not got a BMI of 16 or something. And a nutrition consultation for pretty much anybody that's going for major head and neck surgery.
Sure. Yeah, that's pretty much all I think you can do for this patient. And then you got to get into surgery, right?
Yeah. This guy actually, because he had so much trouble getting back and forth from his assisted living, it took him like 2 months to get to surgery. It was really sad.
Yeah, that's always a balance. So this guy just magically healed up, right? You didn't have to do anything. It was the betadine that cured him. Yeah.
So after about 48 hours, his neck did look cooled down. It was less red, less tender, but there was still copious saliva coming out. Gave it a couple of days, couldn't keep up with the packing. It was all completely saturated with saliva. This was clearly a high volume fistula. It was not going to improve with conservative management anytime soon. So I decided to take him to the operating room. We found about 1.5 centimeter defect in the mid-pharynx closure. Washed everything out, cleaned it out, thoroughly irrigated everything, refreshed the edges of the fistula site, imbricated this, and then I did a pec muscle overlay. Put JP drains back in there, and then he actually did great. He got a swallow, I guess, 10 days later, and was home on a diet, back to his assisted living.
Awesome. I think we have a couple audience poll questions that kind of tie into this part. So JJ, if you want to go ahead with the first one. So I think we were going to go over which of the following options would you do at the time of the take back in terms of reconstruction.
I'll close the poll in 5 seconds. Closing now.
I see. It's kind of across the board. That's pretty good. So Caitlin, you went ahead with the onlay, but at least I found, and we can ask some of the panelists as well, that when I try to inset within kind of friable fistula tissue, it just doesn't feel very good. But we can kind of get people's experiences on this. I think, let me see who we haven't really talked to. I guess, Karen, we can see what your preferences are onlay versus inset within the fistula area if you're trying to close one of these.
Yeah, even in the, say, radiated setting where you're just trying to reinforce, say, regardless of the fistula, I always like to bring the skin. I think you bring the skin and inset it, it gives you two, at least, surfaces that are well vascularized that you're suturing to. In this case, I don't think you were as worried about the vascularity of that mucosa, but obviously something went wrong. So I like putting the skin in, and then I think you probably still had enough mucosa, but the more you cut out, the more you might run into that stenosis down the line. So if you put that skin in there, I think maybe you're heading off that repeated dilations down the line.
Right. That's a good point. I think we have a second poll question regarding the use of salivary bypass tubes, whether or not people will place them or not.
Close the poll in 5 seconds. Closing now.
I was expecting a 50-50 split, but I guess not here. Yeah, I think we also have Dr. Rosenthal on. I would be curious as to what your thoughts are about placing a salivary bypass tube and whether you think it helps or not. I know people go back and forth about it. I used to use them a lot, and I haven't used them nearly as frequently as I do now, especially for fistulas.
I'm not sure that they actually really help that much, but they make you feel better about yourself.
Yeah.
So, there tends to be this thing where I don't know if a foreign body really helps the healing process, but it might, if you have a frank fistula, it might help reduce the overall. Sorry about that. It might help reduce the gross saliva coming out the neck. That's my feeling.
Yeah, totally. Is there any of our panelists who were just absolutely not using salivary bypass tubes? They've totally stopped using them altogether.
I'll chime in there. There was a paper from Bruce Hoey at WashU, which looked at 250 some free flaps, and he looked at specifically at fistula, and it turns out salivary bypass tubes did not reduce fistula. And in fact, there was some association with actually long-term fistula stenosis development. And so the thought there might be what I've been describing, that having a foreign body there might have actually been causing some problems. So not helping, but even potentially hurting. So, as I left WashU as a resident, I think I carried that, heritage with me. And so I pretty much never used bypass tubes.
Yeah, I really only use them in the case of a frank leak.
Yeah.
Yeah.
Same.
I think we have 1 minute left. And I think the important thing here, Caitlin, like you highlighted, is you got some vascularized tissue up there, which is really the key in this kind of situation. And you did end up taking this patient back fairly early, recognizing that the leak wouldn't close on his own. Would any of our panelists wait a little bit longer? Say, give them a week, see if this kind of slows down, keep packing it, or, at kind of a couple days, would you go ahead and move on and try to get this patient, on to further therapy?
My question would be, was the initial opening on post-op day 4 done in the OR?
No, that was done at the bedside.
Yeah, because I kind of, looking at the timing of this post-op day 4, to me, the most important layer of closing a laryngectomy defect is the skin actually sticking down.
Mm-hmm.
And that on post-op day 4, the skin hasn't stuck down yet. So you're going to have a big cavity that this can spill into. And so I take the initial opportunity at the washout to just get a sense of what I'm dealing with. And if I'm dealing with a 1.5 centimeter defect in the pharynx, you might have an opportunity to throw a stitch and just slow things down, get the neck cleaned up, and then decide later if you need to do more. So I would say that's one thing. Yeah, I like to do pretty early. Again, depending on the amount of saliva, but I think early on your skin flap wasn't stuck down. I'm sure.
Yeah.
The other question I'd love to ask the group is, who does their incision separate from their stoma, and who does their incision with their stoma incorporated?
For me, it depends if they have a trach or not. So if they had a trach before, I'll excise the skin and make that part of the stoma. But if they don't, then I do a separate incision.
Yeah.
I'll
I changed
always
mine.
include the stoma
What's-
with the incision.
Always?
Always,
What's
yeah.
it? Yeah. So I had Franz Silger come give a grand rounds here. It's got to be about 8 years ago. And I changed my practice from stoma always in the incision to stoma never in the incision, including tracheostomy.
Oh, really?
And it's been life-changing. In the sense, when you get these fistulae, they never involve that trifurcation of the stoma, which is just a nightmare. And you almost never get tracheal stenosis that you have to revise later.
Wow, that's a good point. I too have been an always in the skin incision type of person, but I've heard very convincing arguments from the opposite side that I'm really thinking of
It's
switching.
life-changing, literally, yeah.
Not to downplay it, right?
Yeah.
Do you make your incision just higher, or do you try
Just make it
to?
higher. You
Yeah.
gotta have you have to have at least 2 centimeters of skin in between.
Okay.
And then I make a 2 centimeter circular cutout. And if the patient has a trach, you use their previous trach site as the stoma.
Nice. Well, we're a little
I
bit
think
over
we're at
time.
time. Yeah.
Yeah, so if we could probably just move on to, I think Camille, you are up next. We can get your slide shared.
I'm Camille. I'm the current fellow at Northwestern. I'm sitting next to Dr. Patel outside of our end of year shenanigans. So excuse me for the glare. So this is the case we're presenting on an oral cavity resection and reconstruction. So a little bit different, but you'll see some things repeated. Hopefully we'll still have a robust discussion. So this is a case of a patient who came in, 64-year-old male, complaining of a cheek sore. He had had a bite trauma to the buccal mucosa, and that had not healed. His past medical history was significant just for hypertension and prediabetes, no relevant surgical history. Of note, he was a 30-pack year smoker, had quit the month prior to presentation at the time that he was seen outside of at an outside hospital. Occasional alcohol use, worked as a bus driver. His biopsy at an outside hospital demonstrated moderately differentiated squamous cell carcinoma, P16 negative. And this is a photo of the lesion. So here it is. It's pretty much right up to oral commissure, not involving any external lip. There's a good 1.5 centimeters between the superior margin of the lesion and what was palpable and the alveolus superiorly, as well as inferiorly. He probably had 0.5 centimeter, maybe a little bit more of space. And his preoperative workup consisted of CT neck that demonstrated thickening over 3 centimeters on that right buccal region. There was no evidence on scans or on clinical exam that he had any regional nodal involvement. His CT chest was, fairly typical in that he had some sub-centimeter nodules in the left upper lobe, and they recommended repeat imaging. So my first question to the group would be, if this patient came to you as presented, so clinical T2 N0, M0, right buccal squame, how would you potentially, evaluate neck?
We'll close the poll in 5 seconds. Closing now.
Nice. So looks like the majority of people would choose to electively dissect the neck. Sorry, and I don't want to moderate necessarily. I don't know. Does anyone have a strong opinion about why you would choose that or choose something else for this patient?
Yeah, maybe Dr. Cognetti and Dr. Rosenthal could comment. Let's see.
First, look, I think it's good to do a PET CT, but it wouldn't help me decide. A negative PET CT is not going to make me not manage the neck in this tumor. And I do sentinel node biopsy. I believe in it. I don't trust buccal tumors, especially big buccal tumors, and a buccal tumor that I know this is local regional reconstruction, but a buccal tumor that's probably getting radioforeign free flap. So this patient's getting an elective neck dissection.
Great.
Yeah, I totally agree with that. I don't think, I think in Europe they would still do a sentinel lymph node biopsy. But I agree. In the US, everybody's going to do that because they're going to need a free flap for the buccal reconstruction.
I'm not mistaken, the Cruz et al. Study with a randomized to elective neck dissection versus expectant management had a large number of buccal mucosas because it was done in India. And I think it still shows a benefit for elective neck dissection. So I think we have some of the most robust level 1 data in head and neck is in this particular space favoring elective neck dissection.
Over observation, not necessarily sentinel node biopsy. Just got to throw that clarifier. Yeah.
Yep, absolutely agree with that. Yep.
Yeah.
And then also, like, was that in the context of a negative PET CT?
No, it was not. Correct.
Yeah. So I mean, so the PET CT, you can still justify that in some ways, but it still wouldn't change what I did.
Right.
Great. Thank you, guys. I can advance the slides here. All right, so we concurred. So we made a surgical plan for a wide local excision of that buccal lesion and a right elective neck dissection addressing levels 1B, 2, and 3. So here's a picture of our buccal defect. And we elected to get frozen section margins, and the pathology demonstrated moderate dysplasia at that superior margin, negative margins anteriorly, inferior, and posterior. And then our deep margin, we took a representative section, was just skeletal muscle, no evidence of carcinoma. My second question is, if you had that come back on your frozen, what, if anything, would you do about that superior margin? Re-resect some small amount and just send it for permanent? Would you, say that's not severe and leave it alone, or re-resect and send it for frozen, knowing that you may end up taking even more if it continued to say moderate dysplasia?
Closing the poll in 5 seconds. Closing now.
Interesting. So I'm glad I asked a more controversial question. Does anybody want to talk about their rationale for any one of the choices that they chose? They would consider.
I think that's a great
Kieran.
question, Camille. I think that's a response getting question for sure. I think one of the things to just kind of mention is, the declaration of mild, moderate, or severe can kind of depend on your institution or even your pathologist. And I know some of our pathologists have moved to more of a binary system to help reduce some of that kind of crossover that you can get. So there's no intermediate ground. You're kind of forced to make a call sort of thing. But the moderate category, I think, is really hard. And at least in my training, we stopped at moderate thinking, if we're going to keep chasing this disease for what we would observe. And a lot of these patients ended up meeting criteria for some kind of adjuvant treatment anyway. So maybe we were spared that. Certainly something that was more on the severe, and I would go ahead and re-resect.
And this wasn't a question, but I'd be curious for Karen. I noticed that they didn't do level 1A. And me personally, for a tumor in that location, I know it's not quite to midline, but I wouldn't be comfortable not treating 1A. And I know that could impact some reconstructive options, but just curious what a few other folks might do, not right or wrong. Kieran?
Yeah, I would do 1A.
And would that change what you reconstructed? Sorry, Caitlin.
No, I would as well. Yep.
Urjit, just curious if you could expand on that, and if part of that was due to, you know, kind of what you were thinking from a reconstructive standpoint.
Yeah, so a little bit of both. So one, you may find it will impact the reconstructive option that we ultimately chose, but irrespective of reconstruction, I have to admit I'm not terribly dogmatic about level 1A in a pretty lateralized lesion. So that might be a little bit cavalier on my part, but here it will come into play. But I would admit, even irrespective of that, let's say there was no recon needed, I'm not terribly dogmatic about level 1A in an otherwise N0 patient.
Okay.
Great. And Dr. Liu also put a nice paper in the comment section if you guys missed it, just to take a look at. So moving on, again, this is that final defect. You're right, I didn't change the photo, but this is the final defect. And so the next sort of question here, presuming that we're gonna do that elective neck, is what would you favor from a reconstructive option? Looking at the options here and your own practice, what would you favor?
We'll close the poll in 5 seconds. Closing now.
So interesting selection. For anyone who chose a skin graft and bolster, could you just share maybe some tips or pearls about how you get that bolster to stay? Because I can never seem to get it to my satisfaction. But I do think it's a nice tool in the tool belt for these types of defects.
So I did not choose that option, but what I found is, and it's not that I haven't used it, it's just for this specific defect, I think there was a better option, but I've certainly had sick patients where I find that their oral contractures, at least their problems, and we just need to get the cancer treated. But that said, I make a really big sponge. I don't know if anybody has any other kind of tips, but I use the surgical scrub sponge, like the ones that we all use for our scrub. And I just wrap that in zero form and I tack a stitch through the sponge and on either side. So it's one big stitch going around that just socks it in. And I haven't lost a bolster yet that way. It's honestly a little hard to take out even in clinic. That's the only thing I've found that helps.
Can you leave that for about a week or longer?
Mm-hmm. Yep, about a week. And it's nice because it's a sterile sponge. You know, it doesn't soak up all the spit like the cotton balls. It's a little bit cleaner.
I'm curious with Dr. Cognetti and Dr. Rosenthal, if they've got any comments as folks who have a little more gray hair than some of us, and maybe lived in that skin graft era a little bit longer. I mean, is that something they find, if even in patients who don't get radiated? I just find they get a lot of contracture, but just curious if they've had some success with a defect like this from their perspective.
It's pretty variable. You know, it really is. I mean, to be honest, I think it works fairly well if they don't get radiated. It just ends up contracting a lot, and you have to really, you know, use the jaw aggressively. You know, have them manage the jaw aggressively to prevent trismus, because it's the functional defect that makes the biggest difference.
Right. Dave?
Yeah, I agree. The radiation kills just about everything in the buccal area. You're going to end up with a trismus risk almost no matter what you put here, but certainly a skin graft. In terms of tricks with skin grafts, I wouldn't be shy about going through the skin and bolstering through the skin on the outside. Put a little pledget or something and tie your knot down on the outside. But I wouldn't use the skin graft here. And another bolster trick that for more superior bolsters for palate stuff, we'll secure it in place with suture and then put an aquaplast molded on top of the bolster and secure that in place too as a sort of scaffold to hold it up. But I agree with Eben. You know, the buccal stuff just contracts, even the free flaps.
Yeah.
A question
Great.
for the group, just with regards, and I apologize if I missed it earlier, addressing the parotid in an instance where the duct is, the drainage is removed, and I couldn't tell from this, I assumed it probably was papilla. But how does the group address that? Do you just tie it off and let it burn out? Do you go ahead and take it out at the time? Curious to get everybody's thoughts.
I will say it is a problem. So let's say the duct is incorporated in the resection. If on the deep side I can put a clip or a tie on it, I actually will. Because now I've had a series of, you know, forearm or submentals that I put in the buccal, and then you just get this, you know, big seroma, you know, a salivary fistula collection if you just leave it free. If the resection goes right up to the edge of the duct and the duct is still, you know, somewhat intact or right at the periphery of the reconstruction, then I'll kind of ignore it, and it seems like things are okay that way.
Alice, I don't know if you have any comments.
I agree. I definitely make it a priority to follow the duct and try to get a good tie on it, having had to deal with the complications of not doing it. So I'm pretty cognizant of that. And then eventually it does atrophy and then it goes away. And if I have to treat them with some antibiotics, I do. But that is something that I learned the hard way, and I try to find and tie off nicely.
Great question. Thanks, Dr. Moore. Other questions? So I'm just going to share what we actually did. So that's the lesion. There's the defect. We actually did go for submental artery island flap. This is our, you know, plan up front. This is the flap as it was harvested. We took the milo as we discussed earlier today, and then brought it into the mouth. And this is the patient, you know, I think this is like a week post-op. So, you know, his post-operative course was pretty straightforward. There was not any evidence of leak or dehiscence. And we felt pretty good about that. Obviously, he had a little bit of hair growth there in the picture. And his final pathology actually was really favorable. So he just had a T2 N0 M0 with no adverse features. And with the multidisciplinary tumor board discussion favored observation. I know that just a minute ago, we talked a little bit about, you know, buccal squames I think that there's some evidence that they can behave badly in the world of oral cavity. Is there any thought about, would your tumor board have made a different recommendation with this past report? I see a lot of head shaking no, so good. Anyway, I just wanted to share a couple slides to highlight some of the vascular supply of these local flaps. We didn't today talk about a superclav. Just so happened we got two of the same, but that's obviously another good choice for different head and neck, you know, defects. And some of the things that I have found and we talked about today are that, you know, you can use a submental when you have a need for shorter operative time, patients that would not tolerate some of the microvascular anastomosis or, you know, prolonged monitoring in an ICU. Sometimes you can avoid a separate donor site if you're already going to be dissecting the neck, and they tend to have a better color texture match to the face. We also touched on some of these patient selection or contraindications, relative contraindications. Somebody has level 1A disease, poor skin laxity, if they've been previously treated. We talked about radiation.
Sorry,
changes.
we're just about to end and come back in.
I
But,
didn't realize you guys were still here.
Oh, sorry.
Thanks a bunch.
anyway.
So radiation fibrosis or possible previous neck dissection, in particular, if we're not sure whether or not, those vessels are even intact and usable. And then I did think that this was a relevant point because I think the majority of the panelists and discussants would have chosen a radial forearm for this patient. But there are some good studies that, and obviously you see that Dr. Patel published one of these. So I have a bias that you can have good outcomes with the submental for oral cavity reconstruction, and that the oncologic safety has been looked at. And for a patient who's negative and you feel confident is lateralized, there is some data that you're not compromising this patient's final sort of oncologic outcome, which continues to sort of, I think, plague the minds of head and neck surgeons everywhere. So this is just a, survival curve of patients who, in our hands, and R is a global we, Dr. Patel's hands, received radial forearm pre-flap versus submental flap for reconstruction. And there was no significant difference in recurrence between the two groups. And I know we're probably short on time. I can go through lots of figures, but I did think that that was worth at least pointing out. And then our patient is 14 years out from his primary, so I did not do this case. He had no evidence of local recurrence. He did actually require laser resurfacing of that flap so that he didn't have a beard growing in his mouth, and unfortunately did develop a second cancer, and currently is just following his medical oncology.
Awesome job.
Awesome case. Yeah, that was a great case. Thank you guys, everybody. I know we're a little bit over time, but I think these were some really nice cases and just kind of goes through all the options that are available to us that aren't necessarily pre-flaps and when we would use them.
Yeah, and thanks everybody who joined us. I know everybody's busy, and really appreciate David, Kieran, and certainly our other panelists, along with obviously Urjit. And yeah, it was great. So Dr. Moore, anything else from your end before we sign off for the last time this year?
No, just wanted to thank everybody. It's been a great year, and congratulations to the fellows. Really thank all the presenters and the discussants. Also, thanks to Dr. Rosenthal and Tranisha and Jeff Liu and all the faculty who took the time to call in. Really awesome session. I always feel like I learn a ton from all of you, and I know the trainees do as well. So thanks so much. We're working on the curriculum for next year, likely going to adjust it to do one session per month just to try and walk the line of maintaining momentum but minimizing burnout on these sessions, just in the context of what's being done, especially because there are a lot of other parallel sessions as well, and we'll be in touch with everybody about that. And for the trainees who enjoyed this, who want to be involved in it in the future, always feel free to reach out to me or Babak or Arno or any of the other members of the curriculum development and maintenance service. We'd love to have you on board. So thanks so much to everyone for being involved. Have a great night.
Thanks, everyone.
You too. Thank you.
Awesome. Good night, guys.